Good morning. It is a pleasure for me to be able to present to you on my research. Unfortunately, I was unable to attend the conference because I came down with COVID, so I'm back in Sydney, but hopefully this video will be useful and I'll be able to join live in the Q&A afterwards. So the topic of my presentation is insights from real-life data on the cause of falls and fall-related injuries in long-term care. And I'll start by saying that some of the videos that I will be presenting are difficult to watch. They illustrate real-life falls in older adults, including some videos that produce serious injuries like hip fracture and impact and injury to the head. So we're well aware that falls are a major health problem for older adults. It's especially true in the long-term care environment that we study, where about 60% of individuals in long-term care will fall at least once per year. See that about 20 to 40% of falls result in some type of injury. Only about 2 to 5% result in serious injuries that cause hospital visits. But the problem is that falls are so common that these serious injuries add up, and falls indeed are a top 10 cause of death for older adults. They cause 95% of hip fractures and about 80% of traumatic brain injuries in older adults. Now, the work that we've done with the real-life data have attempted to address some of the gaps that exist in our understanding of like how and why falls occur. So what I'm going to take you through are some of the key findings that we've come up with regarding these questions of what are the most common activities at the time of falling, and what are the sort of biomechanical causes of imbalance that lead to falls in older adults in the long-term care environment. What are the factors that separate injurious and non-injurious falls? And what are the effects of wearable hip protectors on hip fracture risk during falls? The work involves a partnership with 2 long-term care homes in the Vancouver area. So mostly what I'm going to talk about again is like the video capture falls, a little bit on hip protectors, and here's kind of an overview of the video capture. That in these 2 long-term care homes, there are networks of digital video cameras in common areas like hallways, dining rooms and lounges, no cameras in bedrooms or bathrooms. And over a 10-year observational study in these 2 long-term care homes, we have collected over 2,500 falls experienced by over 700 residents. The average age of the residents is 84 years. Injuries are documented on fall incident reports and confirmed by checking medical records. And we have access to full medical records for about half of the cohort. And similarly, for about half the cohort, we have consent for sharing video images for research and education. So all of the images, like including the ones you see on the slide, the videos that I'm going to show, we have the consent of the individual for sharing for research and education. And in that regard, I encourage you to contact me if you're interested in getting access to a subset of 300 videos, which we have posted through a network called Databerry, which is based at NYU. And again, please contact me if you're interested in that. So here's a video that I'll start in showing, which kind of illustrates some of the complexity of fall prevention in this environment, and also the complexity of falls just in terms of like the activities and the causes of imbalance and so on. So let's just look what happens here. This care provider is trying to encourage this woman to use their walker, and also allowing the individual to sort of decide not to use their walker, to go over to that table. But you can see how unsteady and just how challenging it is to prevent that fall. So we have video like that, and then the task for us is to generate data that we can then analyze. So our approach has largely relied on the development and application of structured questionnaires that we have validated. These questionnaires examine features of the initiation, descent, and impact stage of the fall. So we're interested in things like cause of imbalance and activity at time of fall. We're interested in the direction of the fall and the landing configuration, whether there are attempts to recover balance by stepping and grasping, and then what types of impacts are there to which body parts and so on. So we've got this video evidence that we translate to actual data based on this approach. We also have, as I mentioned, have injury data that we then link with that video evidence. And for a large portion of the cohort, we have information on disease diagnoses and physical and cognitive status. So let's talk about, how falls occur. Like, what is the activity at the time of the fall, and what is the cause of imbalance? And here we see a mosaic plot, which is a sort of bar graph where the widths of the bars correspond to like how common that particular category is. So on the horizontal axis is the biomechanical cause of imbalance, and on the vertical is activity at the time of falling. So we can see that the largest category is incorrect weight shifting. The second most common cause was loss of support with an external object, followed by trip, stumble, and then hip bump. You see that slips are a very small portion of falls in this particular setting. Now, the other thing that we can look at, if we just focus on, incorrect weight shifting and what was the activity at the time of, falls leading, caused by incorrect weight shifting, it's almost kind of equally divided between the activities of walking, transferring, and standing. Other causes of imbalance, like trip, not surprisingly, occur primarily during walking. But let's look in more detail at like what are the top 10 activities at the time of falling. So here, we've got our four major categories I've grouped together, transferring like sit to stand and stand to sit. So we've got walking, transferring, standing, and seated as kind of, color categories. But you can see that the number one activity at the time of the fall was like walking forward. Now, if we look at all the green categories, which are like walking, you've got walking forward, walking and turning, and then walking sideways or backwards. If we look at the purple categories, which we're standing, again, we've got standing and weight shifting, standing and reaching, and then just standing still. Now, if we look at the blue categories of transferring, we see that moving from standing to sitting, and in fact, it's the termination stage of that activity, that was like the third most common cause, or I should say activity at the time of fall. So really that was, situations where people were missing the chair during sitting. Also associated with, falls in, during transferring were falls during sit to stand, either during the initiation where imbalance was lost during the initiation of that kind of transfer, or in the final stage and sort of achieving a stable upright configuration. And then finally, we have, falls just while seated, which involve sliding or shifting off the chair. One thing that we've looked at recently is how often did people attempt to recover balance by stepping during falls that were initiated during standing. Indeed, we saw that steps were common, that 3/4 of falls, 76% steps were initiated. And 80% of those cases involved execution of more than one step. 82% involved the step being executed in the same direction as the fall directions. And then finally, we saw that the majority, 64% of occurrences of stepping, the step was small in size, perceived to be less than half a foot length. But I think overall what we're seeing here is, people are recognizing and reacting to the fall, executing steps in a sort of functional manner in the sense that they were directed in the same direction as the fall. Sometimes steps were executed in directions other than the direction of the fall when someone, like in this case here, was attempting to reach for an object that was in a direction different than the direction of the fall, in this case, forward direction. Now, let's go back to talk about the causes of imbalance leading to falls. And here we're seeing a bar graph of the top 10 causes of imbalance leading to falls. And what I've done here is group them according to whether we would regard the perturbation as an internal perturbation to balance or an external perturbation to balance. We see that internal perturbations to balance are about twice as common as external perturbations in causing falls. And what I'm going to do now is sort of go through several of these causes and show you examples of falls due to these various scenarios. Let's start with the external perturbations, and we might regard these as being perhaps easier to prevent due to the fact that they're often associated with environmental hazards. So these are the ones that are shown in sort of the orange, and the top external perturbation to balance causing falls is loss of support with a moving object. So let's play the video, and this is a pretty common example of a scenario where the individual falls as the wheelchair moves under them as they attempt to sit down on it. And, I talked to my engineering students about how we need to design wheelchairs that have self-locking brakes that won't move until the individual is completely seated on that wheelchair. And that is going to hopefully prevent a fall like that. You can see here that we have a category pushed, pulled by another person. And yeah, unfortunately, what we see in the long-term care environment is 9% of falls are due to this scenario. Let's look at the next scenario where a foot collided with a raised object. And here, this is, of course, a type of trip where the individual impacts a raised object. And this was a scenario where a game was being played, and unfortunately, this equipment wasn't moved away, and the individual trips over that equipment. So just like what we saw with the wheelchair moving underneath the person, this is the kind of fall that we really would regard as something that could be prevented. Now let's move to the scenario of internal perturbations to balance, and we see that the number one cause of falls is excessive sway. And let's look at an example here where this individual standing and sort of staggering due to what we call like excessive sway. And we might think that this kind of fall would be prevented by the individual using a walker. Now let's look at the next most common internal perturbation to balance causing falls, and that is, as I mentioned, like missing the chair while seated, while attempting to transfer from standing to sitting. And can we see this very common, 13% of all falls. And we can just see the individual is not well positioned in attempting to sit down, relative to the position of the chair. This next scenario involves imbalance while attempting to rise, and this person actually successfully rises, but really doesn't establish a stable position and falls after rising. Now, the next scenario here is a misstep during walk. It's often difficult to differentiate these falls from trips. So what we'll see is that this individual is walking with a fairly normal gait, but all of a sudden the person takes a step that is much shorter than the other steps, and her center of gravity moves forward over her base of support, leading to a fall. This fall, unfortunately, actually resulted in a hip fracture, and it's an example of a type of fall that we see that is actually quite common in the scenario of hip fracture, where the individual starts by falling forward, but then rotates to land sideways on the hip. But let's concentrate here on examining the misstep right there. All right, so we look pretty extensively there at what were the scenarios that caused falls. Now I want to transition to talk about injuries during falls, and particularly focus on the problem of head impact and injury. We were really surprised when we started, this research in noting that head impact was a common occurrence. Indeed, 1/3 of falls caused impact to the head. And when we started looking at the injuries, we saw that 35% of all injuries were to the head. And here we're seeing these sort of bubble graphs showing like the different contact sites. And here we see the head, 33% of impacts. Other body parts like the torso, the hand, the elbow, were even more commonly impacted. But again, the largest percent of injuries, 35% of all injuries, were to the head. So if we plot the number of impacts to different body parts against the number of injuries due to impact, we can see that the head has this much higher rate of injury in the event of impact than other body parts. These other body parts were impacted more often. So it appears that individuals fall in a manner where they're much more likely to impact body parts that are less vulnerable to injury. But something is happening for older adults in causing impact to the head, the most vulnerable body part for injury in the event of impact. So we've been interested in understanding, well, what are the factors that associate with risk for head impact and injury during falls? And I'll show you some videos that illustrate some of the ways first in which older adults are successful in avoiding injury. And we're going to see in this first fall and in I think a later fall, a backward fall where the individuals first land on the pelvis and then are able to use the core muscles to kind of maintain the torso in a near upright position, the head off the ground. They're also using their outstretched arms to impact the ground. And so I think that a big thing in backward falls and sideways falls is that you have this impact of the pelvis that allows, a lot of the energy of the fall to be absorbed. And, what we'll see is that forward falls have a much higher risk for impact to the head, in partly, I believe, because you don't have that impact to the pelvis. But one thing that we'll see here is some rotation from forward or sideways to land backwards. So, it's actually very common. We saw this rotation during descent, another surprising thing. So here's that backward fall, landing on the pelvis, keeping the torso upright. Here's a forward fall, kind of rotating to the side. Again, here, rotating to the side, using the outstretched arms. And here's a fall, initially sideways, but rotating to land backward. Now, the next set of videos are the ones that are especially hard to watch because they all involve head impact and quite severe head impact. We'll start by seeing a forward fall where the individual attempts to arrest the fall with the outstretched arms, but the arms collapse, leading to head impact. Then we're going to see some backward falls that, despite impact first to the pelvis, there's a lack of control of the core trunk muscles, and perhaps the neck muscles, leading to this sort of whip-like motion, leading to head impact. So very brutal. Here's a scenario where head impact occurs, but I'm including this one to show environmental factors that may influence, that may either be hazards or facilitators to safe landing. And this is work that Natalie Shishov, a PhD student in my lab, is now doing, exploring environmental complexity. And I think, as you see in many of these falls, people are not falling in empty rooms, but rather in complex environments where external objects may be facilitators to safe landing, force balance recovery, but also hazards to impact of the head and injury. Now, we look at the factors that influence risk for head impact. First, we're seeing some demographic and physiologic factors, and we can see that females are over twice as likely to impact their head in falls in long-term care. And maybe this has to do with upper limb strength. We saw arm collapse was a big problem. Individuals with poor vision were more likely to impact their head, maybe because they couldn't perceive and coordinate the fall to the environmental complexity or environmental factors. Cognitive impairment actually decreased, and physical impairment had no effect. So it's not as if the problem of impacting the head during falls is restricted to the most frail residents. Rather, it's the most active residents, often individuals who have the least amount of cognitive impairment. And some of that relates to what I'll show in this next graph, having to do with the biomechanical risk factors, and seeing that falls during walking were the most common to cause head impact, twofold increased risk for head impact. And so those individuals who are more active are more likely to experience falls during walking. Also, falls during walking are associated with falling forward and landing forward. One thing we see that I mentioned is that rotating from forward to land sideways, and especially if you can rotate to 180 degrees to land backward, that reduced the risk for head impact and injury. And finally, hand impact had no effect. So this is something that's really surprised us. What I regard is that, impact or to the outstretched hands and sort of bracing the fall with the outstretched hands, no doubt it is sometimes protective, and it is probably essential for reducing the severity of the impact, but it's not sufficient in itself for avoiding head impact. So again, I think this has to do with the biomechanical demands of that task. It's very strength intensive, and older adults in long-term care tend to lack the upper limb strength. And so I think that's why you see some of these alternative strategies like rotation during descent emerging. Now, here I want to talk briefly about a study that we recently did on predictors of mortality in this population that we're studying in long-term care. And what we are seeing is that longevity, life expectancy, does associate with falls. We divided individuals, the higher fall rate group and the lower fall rate group. And we found that individuals in the higher fall rate group had a 43% higher risk for death. We also found that females had a longer life expectancy. They lived 56% longer than males. And this was one of the main reasons why we did the study. We were trying to understand, does head impact during a fall influence mortality? And indeed, we found a significant effect of head impact, that individuals who impacted their head in all of the falls recorded on video had a 50% higher risk for death than those who didn't impact their head at all. Now, let's briefly talk about hip fracture and what we've seen with regard to the benefit of hip protectors in long-term care. So hip fracture only occurred in 1.5% of all falls that we recorded, yet it was, the most common reason for hospital admission. And I showed you already a video that, if you recall, that involved hip fracture, where the individual was walking forward. They started falling forward, but they rotated to land sideways. And here we'll see another fall that caused hip fracture. And what was common in these falls, and this was the work of Yijian Yang, who I believe is at the conference, and so you can talk to him. He's done like a lot of the work that I'm presenting in this presentation, but he looked here at characteristics of falls causing hip fracture. And what was common is like what we see here, where it doesn't seem like it's a particularly severe fall. Almost all the falls causing hip fracture occurred from standing height. But what is severe for the hip is that almost all the energy of the fall is delivered to the lateral aspect of the hip. Now, here's what he found in terms of risk factors for hip fracture in this population. And somewhat surprising, osteoporosis diagnosis was not a significant risk factor. Impacting the hand, just like we saw with head impact injury, was not predictive of hip fracture. Falling sideways and falling forward created a similar risk for hip fracture. The key thing was landing sideways. So again, like a lot of these falls that initially started forward that ended up landing sideways, these were the ones that were often causing hip fracture. Now, finally, if we look at wearing hip protectors, it reduced risk for hip fracture by over twofold. And this is something that I think that's quite interesting. We're seeing that use of a mobility aid while falling, like holding a mobility aid while falling, had a really substantial effect in reducing risk for hip fracture. And in more recent work, we're seeing that it is also protective against head impact and injury. So, it's another thing that people haven't really thought about, I believe, in terms of like the benefit of mobility aids, of rollators and walkers, that even if someone falls while using these devices, the fall will tend to be less severe, especially with regard to hip fracture and head impact and injury. Now, with regard to the effect of hip protectors, this is work that was done by Alex Coral during her PhD. And she looked at 14 long-term care homes in the Vancouver area, and she examined how many of those falls resulted in hip fracture, how many of these falls involved people wearing hip protectors. And what she found was that 60% of falls, of these total of 3,520 falls that she examined over 1 year, in 60% of the time, people were wearing hip protectors. So that's an immense success story with regard to like uptake and ability to like encourage, get people and have people in long-term care wearing hip protectors. And then in this study, she found that there was a 2.8-fold lower risk for hip fracture in falls where the person was wearing a hip protector versus not. There was no effect on pelvic fractures or other type of fractures. But yeah, I think, again, like this is indicating hip protectors are valuable, reducing risk for fracture by 2 to 3-fold. And we can get people to wear hip protectors in the long-term care environment, where we can sort of set up the infrastructure of support and encouragement that facilitates uptake with hip protectors. And we are now doing work with Kate Sibley, who is also at the conference, on understanding how is the success achieved in British Columbia, in Fraser Health, among these 14 long-term care homes, where again the average uptake was 60% with use of hip protectors, and how can we translate that model and tailor it to the needs of other sites in Canada, specifically in Ontario, where the current use of hip protectors is much lower. So maybe you can talk to Kate about this particular project. So finally, I'd like to acknowledge my partners and other research collaborators and my funding sources. And again, hope to be able to take some questions during the Q&A. Thanks.